Good afternoon and welcome to our first podcast on the management of heart failure in primary care and specialty care. I'm Jennifer Gray. I'm one of the clinical pharmacy providers here in Hampton. I'm with Academic Detailing and excited to introduce you to our facility-wide process improvement project team, really aimed at increasing medication management and improving outcomes for our veterans with heart failure. So thank you for joining us today.
Hi, I'm Paco Fielding. I'm a primary care physician in Prime 5, the Prime 5 clinic, the primary care lead in the heart failure pilot.
I'm Dr. Daniel Seidensticker, one of the cardiologists here.
Hi, I'm Amanda Duman. I'm the clinical pharmacy specialist in cardiology clinic.
Hello, I'm Jeanette McWhorter. I'm also a clinical pharmacy provider in Prime 5.
I'm Antoinette Gilliam. I'm a primary care RN for Team 04 with Dr. Obane in this CHF pilot.
I'm Dr. Locchio, primary care doctor, Prime 5.
Natasha Williams, nurse practitioner in Prime 5.
We'll go ahead and Dr. Obeng is going to get us started with our podcast. Thank you.
All right, great. Thank you again, everybody, for coming. So basically, it's going to be more of a question and answer and more free-flowing in terms of our conversation here. So we have a couple of scripted questions, but we'll kind of base it off of that and kind of go from there. So we'll start off with the scripted questions first, and then we'll kind of expand from that point. So we have a first question. So I have a question for Dr. Seidensticker. Basically, I have a patient who's here who recently followed up with me in the clinic. He was recently discharged from the ER. They told me he had heart failure. In the ER, it seemed like they gave him Lasix. He noticed that he felt a lot better. So they basically, they sent him home. He is a 58-year-old African-American man with a history of hypertension, hyperlipidemia, does smoke, overweight, does also have sleep apnea. He knows that he feels a little bit better, but he still has some swelling in his legs. He's not been really active since he was discharged. He's currently on hydrochlorothiazide, aspirin, atorvastatin. And in terms of his pertinent vitals for me in the clinic, his blood pressure was 160 over 95, heart rate was 95, oxygen saturation was 98% on room air. He's about 245 pounds roughly. On exam, pretty much normal exam, except he does have 1+ edema. Heart rate is good, no murmurs, lungs were clear. I did do labs on him, and he did have a creatinine of 1.3. His potassium was good as 4. His BO was 14. So my first question for you is, what would you recommend that I do for this patient, especially since I don't have an echo at this point?
Yeah, absolutely. So this is a very common scenario. So what would be very helpful for you at primary care is first try and see if you can identify a cause for the heart failure. So first, is there any signs or symptoms suggesting ischemia? So make sure that he's not having any angina, make sure he's not having any exertional chest pain or chest pressure. Because if he is, and in heart failure, I would rapidly then try and get a stress test and make sure that we're aware so we can see him fairly quickly if the stress test is positive so we can treat the ischemia. Secondly, I'd really want to make sure, if he's having any syncope or presyncope, that would make me think he's high risk for arrhythmia. And then I would also see what his family history is. So if his family history is everyone at the age of 58 is having sudden cardiac death or everyone's having heart transplant, again, that's someone we need to see sooner rather than later. So first, you really want to try and see if there's an identifiable, treatable cause that we can address in the primary care setting.
All right.
And then also, see if he wants to get better.
Yes, that's the key, right? Does he want to get better?
Does he want to get better, and will he be participating and trying to come back? Because that's really going to see how frequently you want him, how aggressively he'll come back. Will he come back in a week, or is he maybe not going to come back?
Yeah, definitely. And definitely, us having the ability to have clinical pharmacists to help us out, especially for titration of meds, is great.
Absolutely.
It's a great resource. Okay, well, thank you so much. So basically, digging further into his history, his mom does have a history of hypertension and heart failure. And he also notes that he does have a little bit of chest pain randomly, when, but not when he's walking. No, he hasn't had any syncopal spells, but he hasn't been checking his blood pressures, and he knows that he does want to get better. So I would say, what are your thoughts?
Yeah, so it sounds like he's pretty stable. Doesn't sound like he's got a lot of high-grade ischemia going on. So, and sounds like he wants to get better. So I would first, if he's still short of breath and you still think he's got some fluid on board, I would try and get him decongested. So I would definitely try and get him on some Lasix to try and get the volume off, and he'll get some should get some symptom relief with that. I would definitely want to try and get the blood pressure down. And so this is where I would probably I'd probably stop the HCTZ, and I would try and get him on losartan. So losartan, regardless of the echo, losartan would be beneficial in terms of lowering lowering the blood pressure and try and prevent any remodeling of the heart tissue. So that'd be very beneficial. And then finally, I think this would be a patient where I would really consider starting empagliflozin or Jardiance. Jardiance has been shown to help symptoms in all types of heart failure. So without having the echocardiogram, I think it would reduce his chance of coming in the hospital. I think empagliflozin would also help with some of the getting rid of some of the edema and helping with his shortness of breath. And then ideally, I'd have him come back in a week or two to either see you, or this is where having him see the clinical pharmacist, where then they can see his labs and blood pressure and then really make a change in his medications.
Awesome. Thank you so much. I appreciate that. Now, you mentioned about switching him to losartan, right? I had a question though, shouldn't heart failure patients pretty much every heart failure patient be on some kind of beta blocker?
No.
Okay.
Heart failure patients with a heart function less than 40%, absolutely, all of those patients should be on a beta blocker. But patients with normal LV function, beta blockers don't have much benefit. And then also, I really want to try and get them decongested. I really want to try and get the volume off and unload the heart before I give them a beta blocker. So that's where giving them Lasix, getting the blood pressure down, and then once they're almost euvolemic, that would be the ideal time to start a beta blocker. So again, this is where close follow-up is really important. This would be someone where I'd want to see back in a couple weeks, and utilizing either your clinic nurse, your clinical pharmacist, or yourself would be very helpful. Does that make sense about the beta blocker?
It does. Yeah, it does. I appreciate that. And in terms of his Lasix use, what do you think I should tell him about what he needs to know about Lasix and in terms of its management?
What do you guys say about the Lasix? So I've been having Dr. Duman see a lot of my heart failure patients in clinic, and she's been seeing them quite frequently. So what's been your strategy with I know what my strategy is, but what's been your success?
Yeah, it's a really good question. A lot of it, I think, is really getting to know the patient and knowing how savvy they are and how much effort they're going to be willing to do at home. So if you have a patient who really wants to get better, making sure that they have a scale at home is really, really important. They can pick it up in prosthetics same day.
Yeah.
So if they're willing to weigh themselves every day and they're pretty good at managing their medications, then I usually get them on some sort of stable dose of a loop diuretic. And then I tell the patient that if they gain 3 pounds or more in a day or 5 pounds or more in a week, to take an extra dose of their loop diuretic. So if they take 40 milligrams in the morning, take an additional 40 milligrams in the afternoon. And most folks are pretty good with that. Another thing that's really easy for patients to do at home is if they can't tell when they're gaining weight by the use of a scale, their shoes get tight, their pants get tight. They start to notice their socks getting harder to pull on. That's usually a sign that they need to take an extra dose of their loop diuretic.
That's a really good point. I think we need to make sure we emphasize to the patients to recognize what their symptoms are. So we don't want them to wait until they can't breathe at night to come to the ER.
Yeah.
So once they start getting the edema or the abdominal bloating or they're starting to not be able to lay flat at night. That's when we want to make intervention, or that's when we want them to call, because then we can prevent them from coming to the ER. So that's a really good point.
So I have a question on that. So once the patient is considered euvolemic, at what point can you potentially remove the diuretic?
Yeah, so I would say that if they are euvolemic, so diuretics do not help patients live longer. They just kind of help with fluid. So if you can get them on the right medications and they've adjusted their diet, then we don't need the diuretics. So if they are euvolemic and everything's kind of good, then I'll have them use the diuretics as needed. Lasix has never been shown to help someone live longer. It's just, it can keep them from the ER and help them feel better. So we try and get them off of the diuretics as much as we can, as safely as we can. And I tell patients, you may need one a day, you may need one a week, you may need one a month. We just have to figure it out. And then if they start changing their diet and go on a cruise and eat whatever they want, they're gonna need more Lasix.
And I'm glad you mentioned that too, and what you mentioned too, Dr. Duman, about them recognizing their symptoms and then also noticing if they've gained weight or anything like that. And I think that's definitely where our care nurse can kind of come in terms of helping them with management of symptoms, and if they have questions, they can always call her and call, especially on our team and stuff like that too. And I definitely think that Nurse Gilliam, is a good resource in terms of giving education to the patients. And I think you also mentioned that you tell them to kind of check their weights and everything like that pretty consistently.
Weights and their blood pressures, we bring them back for, but one of the things is also talk to them about home telehealth, because home telehealth also help manages the weights, so that when they send them to us, so that we can see the weights, the blood pressures and things too. So.
This is all good stuff. This is very good information. So, I have, coming back to my patient, we made these changes. Unfortunately, his creatinine went from 1.3 to 1.6. Do you think I should stop his Lasix, which we had a nice conversation about just now, or should we look into stopping his empagliflozin, or even stopping his losartan, which we had mentioned it should be a good add-on? I just want to get your thoughts on that.
So it's very, very common that when you start any of these medications, the creatinine will get worse. And what I see commonly is the creatinine gets worse, so the cardiologist, I've seen cardiologists back off on the meds because the creatinine changed a little. And now you're taking away these meds that can help keep them out of the hospital, live longer. So when you start empagliflozin or you start losartan, it's not uncommon to see a 20% rise in the serum creatinine. So I wouldn't ignore it, and we want to watch trends, number one. So I would not read to just back off anything. I just say that's not unexpected, number one. Number two, I'd see what their volume status is. If they are hypovolemic or euvolemic, maybe they don't need the Lasix anymore, and we're just making them get dehydrated. So in that scenario, if they're dehydrated, if they're euvolemic, I would back off on the Lasix. I really would try and hold off backing off on the losartan or empagliflozin. This would be a scenario where I may not go up on the losartan. Now maybe I would add the beta blocker at this time.
Now, in terms of choice of beta blockers, I know typically we'll say like carvedilol is more the kind of go-to option, but what about other things like metoprolol? Are those exceptional? Or I'd like to get feedback as well.
So it's my understanding that metoprolol is the preferred beta blocker after carvedilol. So generally, if I were to initiate, for me personally, a beta blocker, I would typically initiate on carvedilol first. But if the patient is already on metoprolol, for example, I would probably at that point then just maybe titrate the dose as indicated really for that particular patient. I also know that with the empagliflozin that oftentimes the elevations in the serum creatinine are just transient too. And so, definitely keep the empagliflozin on board.
Yeah. How often would you say repeat labs? Would you say maybe in a month or a few weeks? Or?
So for me, I typically repeat the labs within 4 weeks.
Within 4 weeks.
tend to repeat labs anytime I change the Entresto dose. I would check labs after I start empagliflozin. And then if I'm starting spironolactone or eplerenone, I check labs 1 week after I start the medication and 4 weeks, because we're really monitoring the potassium with those specific medications.
Gotcha. That's good to know. It's very good information to know. Okay. Awesome. This is very good stuff. So now shifting gears a little bit here. So for our patients, and I'd definitely like to get some feedback from Dr. Duman in terms of our patients who might be on end stage, basically dialysis patients. Dr. Seidenstecker mentioned about empagliflozin. What's the research on that in terms of like it being a good agent for people on dialysis who also have heart failure with reduced ejection fraction?
Yeah, that's a really good question. So there, I think hopefully will be more data coming out in the future, but right now the data from empagliflozin is for patients who have a creatinine clearance above 20. So I have not been starting an SGLT2 inhibitor in patients who have a creatinine clearance less than 20. I just don't feel like this data is there right now, but hopefully we'll have more data there in the future.
Yeah, definitely. That's good to know, because I do have a lot of patients, all those comorbidities, heart failure, end-stage renal disease, so it's good to definitely know that.
I think working with the nephrologists, if they're at that level, CKD4, I've seen them start the SGLT2 inhibitors, but we need to definitely be on board with nephrology with that advanced level of CKD, kind of on that they're aware of that as well.
Gotcha. All right, so we need to recruit Dr. Reed and Dr. Gill.
That's right.
And I think that's where it's really important to, when you start the medication, making sure you're getting a repeat renal panel within a week or two.
Right.
Because that 30% increase in your serum creatinine, you're willing to accept if there's huge changes. You don't want it to be somebody who's walking that fine line of CKD4 and dialysis, and you just kind of push them off the cliff. So just really close monitoring, and those folks who are who have CKD4 is really important. You don't want to withhold a potentially life-saving medication.
Right.
Give them an opportunity to see if they tolerate it.
Awesome. And I have another, it's kind of a similar case. I have another gentleman. He's a 65-year-old male. Definitely has a history of diabetes, hypertension, hyperlipidemia. Now again, he's presenting to me with worsening shortness of breath, non-productive cough. He does have some edema in there. He weighs about 230 pounds. Blood pressure 140/85. Heart rate 55 beats per minute. His oxygen saturation is about 95% on room air. I currently have him on metformin, rosuvastatin, and amlodipine. His pertinent labs include a creatinine of 1.2. His hemoglobin was 12. Hematocrit was 48. This time we actually did get an echo, and we found he had an ejection fraction of 35%. Would you recommend a standard GDMT on this patient, or would you modify your approach? I'll start with Dr. Seidenstecker.
Yeah, so anytime someone has an EF less than 40%, I always want to get them on a beta blocker, some type of ACE, ARB, or ARNI, meaning Entresto or losartan, an SGLT2 inhibitor. We use empagliflozin here, and then aldactone or eplerenone. And then I want to get them to target dose. So GDMT for heart failure less than 40% is not only on those meds, but on target dose. So absolutely, I want to get him on GDMT. And this patient in particular, so his heart rate is less than 55. You said it was 55?
It was, yeah.
So this is not someone I would start off on a beta blocker right away. I usually don't start a beta blocker or increase a beta blocker dose if their heart rate is 55 or less. So for him, I probably wouldn't go there. I think if he's already on, you say he's already on losartan and empagliflozin?
All right. Oh, no, we just have him on metformin, Crestor, and amlodipine at this point.
Yeah.
So yeah.
Yeah. So this would be someone where that's how I would say about the beta blocker. I would probably again try and get him on losartan and empagliflozin, and then I'd make sure he follows up. Make sure his potassium and renal function are okay, and at the next visit, I would add eplerenone.
Okay.
And I want to try and get him on all 4 of the medications at low dose, and then I'll try and ramp up. to the target dose of Coreg or metoprolol, or the target dose of Entresto or losartan.
And I was wondering with Dr. McWhorter, I guess kind of like the handoff there would be, we've started them on these medications. How would you go about the titration process, or what would be here?
Well, some of it would depend obviously on the repeat lab work and then also the vitals as well. And so I think the care at that point would be somewhat individualized, but with the idea of obviously titrating the doses to the recommended doses, yeah. I would probably consider for this patient, I don't know, I'm a little bit favorable of the combination tablet of the metformin and the empagliflozin, the Sajardi. That makes it a little bit easier sometimes for the patients in reference to the pill burden, especially as we're adding on more medications, and so that could potentially help with the pill burden.
I think as we're titrating meds, one thing I also think is very important, is that you've got to let the patients know that, especially with the beta blockers, that it slows down the heart rate and lowers the blood pressure. So they may get a little lightheadedness and dizziness the first couple of days, and that will pass.
Yeah.
I think if they know it's coming, most of them won't be surprised by that, and they can work through the side effects. Because once they lose faith in the medication,
Right.
they'll never want to go back. So if you let them know, hey, this may happen, just get through it. It shouldn't be that bad.
I think that's definitely where our care manager can come in and kind of encourage them to actually take their medications. And I know you probably had that too, Nurse Gilliam, in terms of patients saying, I don't like this medication. It's giving me a headache or it's making me feel tired. I'm just curious what kind of things you kind of do to encourage them to take their medication.
So usually when they talk about their meds and they don't want to take the meds, then after I explain to them what the meds are for, I say, remember the cardiology, remember the doctor says this or do this. After I explain to them, and then I'll say, well, take your medicines and then see how you're feeling after your medicines. You can send me a note back and let me know. If you're lightheaded and it lasted this long, then send me a message back and let me know that how long it took, for your symptoms to go away. And let me know if they're going on every day or if there's some day. So usually I just ask them to just tell me what else was going on when you took the med. And then I'll say, well, did you take them this time? Sometime, depending on the med, I'll say, well, did you take it at bedtime when you was laying down? Because if it's once a day, sometimes I say, well, try it like right here when you're not going to run around to do a whole bunch of activities, that when you're going to kind of be settled. So it just depends on each person, what they say, what they do with their meds, and then making sure they do know how to correctly take your meds, because sometimes they say, well, I took all these at one time. I said, but it said take this 3 times a day. Well, I thought it meant take 3 pills. No, space them out. So it's just making sure to know that each person, that they're following their directions, that they understand how they're gonna work if you follow the directions. And then if I have problems, then I'm gonna call the doctor, the pharmacist, and say, hey, can you help me with this? Because, especially if the symptoms are going on and on and on. So then I'm gonna come back to you on that one.
That's right. Thank you. And this is a more general question in terms of just heart failure with reduced ejection fraction. I'm sorry, heart failure with preserved ejection fraction. I apologize. And that's basically like someone whose ejection fraction is greater than 50%. What would be your recommendation, Dr. Seidensticker, in terms of those patients whose EF is like 50%, 51%, but they're still symptomatic? How do you go about that?
Yeah, so I think a lot of the principles are the same. You want to address their volume status. But a lot of these patients if you have heart failure with preserved ejection fraction, typically you have multiple other things going on. Most of the patients have high blood pressure. Most of them are overweight. A lot of them have sleep apnea. A lot of them have diabetes. A lot of them aren't exercising. And so really, truly, you want to optimize all those comorbidities. First of all, make sure you're not missing ischemia.
Ischemia, right.
So if there's any sense that there's angina, I wouldn't hesitate to get a stress test in those patients. But otherwise, this is where it's a combined effort. We definitely need to get the diabetes under control. Any weight loss would be hugely beneficial for these patients. In terms of meds, there's not a lot of good meds that have a mortality benefit to it. Do you guys want to talk about the meds for HFpEF at all?
Yeah, I think, the biggest thing for us, our biggest workhorse, like we said, we don't have a lot of tools to work with, is getting them on an SGLT2 inhibitor. That's going to reduce your heart failure hospitalizations. If they are volume overloaded, that's going to help us keep a little bit of volume off. Using an ACE or an ARB for their blood pressure, especially if they have CKD. And then, there's a little bit of mediocre data with using the mineralocorticoid receptor antagonist, so spironolactone or eplerenone, in patients who still are hypertensive, to potentially reduce your heart failure hospitalizations. But usually our go-to is just going to be making sure they're on an SGLT2 inhibitor, and then managing their blood pressure and their other comorbidities.
Yeah. So it seems like the SGLT2 inhibitor is key, regardless of if they're HFpEF or heart failure with reduced ejection fraction. Gotcha. That's good. That's good to know.
We should put it in the water.
We should. Seriously.
Put it in the water along with the stat.
Right.
That
That's
would
like
be
a
good.
take-home message today. Awesome. All right. And then, actually, I'm going to throw this question out towards both Dr. Seidensecker and Dr. McWhorter. So if you have a patient who also has a history of AFib, let's say they're on metoprolol or stuff like that for rate control, how do you go about adjusting their regimen if they also have a history of heart failure with reduced ejection
Yeah,
fraction?
I'm interested to see what your thoughts are.
Yeah.
If they have AFib and they also have HFrEF,
Yes, I've heard this.
okay, so they're not currently being managed for atrial fibrillation.
Oh, they're just on they're just on a beta blocker right now currently, and let's say they're on Eliquis or something like that too.
Okay.
But they're on sorry, this is real random. They're on so they're like on tartrate, tartrate.
Metoprolol tartrate,
Yeah.
okay, and they have HFrEF. So I guess the initial part, I guess for me would be potentially switching over to a more commonly used beta blocker. So probably transition over to the metoprolol from the tartrate, and that, what else are they on?
Eliquis.
Eliquis?
Yeah.
Okay, so then I guess trying to go along with the guideline-directed medical treatment, trying to initiate maybe the ACE-ARB or the, Entresto for that patient. And then I guess maybe assessing, the volume, if the patient is in need of any type of diuresis.
That's perfect.
Yeah.
That is perfect. That's exactly what I want the primary care office to do, is make sure their rate is under control, protect them from stroke with some type of anticoagulation, and then optimize the blood pressure, optimize the volume. So that's perfect. Absolutely. And then if they're having poor rate control or they're having symptoms with the AFib, then that's where an AFib ablation or a cardioversion can really come into play. If we get them on all the right meds and we think that they're still not feeling good and they're in AFib, then we absolutely should think about cardioversion and trying rhythm control. Okay, but when you're seeing them, I don't expect you guys to manage the rhythm.
Right.
But it's so helpful if we can get the blood pressure under control,
Right.
get the volume under control, and make sure that they're not missing any doses of the anticoagulation. So that's a perfect approach.
Yeah. And then with the anticoagulation too, with the ablation too, in terms of bridging and things of that nature, I have to think back to even medical school in terms of preparing them for an ablation. Is there any changes in the guidelines there for?
When it comes to, I would let us handle all
Okay,
that.
okay.
But no, what they're saying going for AFib ablation, they must be on anticoagulation or ablation or cardioversion. They have to be on anticoagulation without interruption for 30 days.
Okay.
Or else we have to do a TEE.
Gotcha.
So if you guys can emphasize to the patient, please do not miss the anticoagulation.
Right.
That would be
That's
helpful.
key right there. Okay, that's good enough. Awesome. All right. And then this is the last one. So I do have another case here. I have an African American patient with a history of heart failure with reduced ejection fraction. His EF is actually 32%. Also has a history of diabetes, chronic kidney disease stage 3. Also has a history of lupus. I currently have him on empagliflozin, carvedilol, Entresto, eplerenone, and as needed furosemide. He's been maximally titrated on these meds but unfortunately, he comes to me still complaining of continued significant shortness of breath, even at rest. Is there something else that you'd recommend? And of course, I start with you, Dr. Sidestick, and please, Dr. Duman and Dr. McCord, please chip in.
Yeah, so I think the first question I'd ask is, how are his symptoms? Like, what is he getting short of breath with no activity, a little bit of activity, or is he getting short of breath with just a minimal activity? Because that's so is he NYHA? If he's NYHA 3, then Bidil has a mortality benefit for African Americans. And that's what the ACC-HA guidelines would recommend. If someone, an African American on optimal medical therapy, is still having exertional symptoms with minimal activity, then that's the perfect indication for Bidil.
Gotcha.
So Bidil is sorry for using the trade name, but it's a combination of azotorbide, dinitrate, and hydralazine.
Hydralazine, yes.
And the problem is it's a 3 times a day medication.
Right. So adherence might be an issue for some of those patients.
Adherence is a very big issue for those patients.
Yeah, I agree, and I think most patients have a hard time taking that 3 times a day medication, but I think a lot of times if you spend time with the patient saying, here's the reason why we would like for you to take the medication, here's the indication for it, and here's the purpose, that sometimes that's helpful in getting them to take the 3 times a day medication, but it's a huge barrier for a lot of these folks. And I think just in general with the heart failure patients, a lot of them are coming into the hospital on very few medications, or they come into clinic on very few medications, and all of a sudden you're asking them to take a lot of medications, to get a lot of lab work, to come to clinic frequently. So spending a lot of time, which I think is where the pharmacist has a little bit more luxury, not always, but we have a little bit more luxury of time to spend going through the medications in detail, asking the patients to bring their bottles with them to clinic so that you can actually see what the patient's taking. Because almost always, if you just go through their list, they say yes, yes, yes. If you have the bottles in front of them, I almost always find some sort of discrepancy between what I think they're taking and what they're actually taking at home. And saying, this is why you're on this medication. It's not just for your blood pressure, but it's to help you get your heart stronger, to help your pump function get better, to help you live longer. Then you get a lot more buy-in to the whole heart failure treatment process, getting them to come back for those every 2-week appointments in the beginning. So tend to find a little bit more success there.
But yeah, what have you experienced, Dr. McWhorter, in terms of kind of pushback from patients in terms of?
Same, and then I find the same. So I frequently will look at the medication refill history too, just to determine if the patients are truly adherent to their medications. And you find oftentimes some gaps in between the refills. And so that's a good indicator that they're oftentimes not taking the medications the way they're prescribed. But I think reiterating the importance of the medications, providing an understanding of why medications are prescribed, the patient education component is really important. And I think once the patient really understands why the medications are prescribed, they're more likely to take them as prescribed. So patient education is truly important. The medication organizers are a nice tool sometimes too. Sometimes just keeping them in the original bottles can be overwhelming, especially when you have a lot of medications. So we do provide medication organizers. We have different types of organizers. I'm partial to the one that divides it up into multiple dosing a day, so that it allows the patient to take the medications in the morning, lunchtime, noon, evening, and bedtime. So that sometimes can be helpful, and that can be ordered through pharmacy.
And then definitely, I'm glad you mentioned about the education piece. That's key in terms of letting the patient know why they're taking what they're taking. And definitely in terms of including nursing on that too, that educational reinforcement too. I'm sure there's going to be probably this patient saying, oh my God, I have all these pills. Why do I take all these pills?
I asked them to bring me their pills because, as she said, when you look and see about the refill, so if they bring you a bottle full of meds, then you didn't take it. And one of the other things is, when they bring their meds, you also see, because sometimes, for instance, if they got their meds from outside, because they'll use the outside, and then they have 2 bottles of the same med and say, well, I took both of these. Well, why are you taking both and not making them know? Or especially if they got a generic name and a brand name, they sometimes don't recognize that that's the same medicine. So one of the things is, when they come to see, I say, bring me your medicine, and they come with the Walmart bag full of medicines, and I'm okay with that, because one of the things is so that we'll learn. Or when they tell you, is it that white pill, when you're asking them something, sir, I can't see your pills at home, so I'm not sure which one is white, so bring me all of them. And when they bring them, you got 5 white pills, sir.
Exactly.
So at the end of the day, it is with those meds, if you bring them right here, it's easier for us to see, but it's also easy so that if I don't recognize a med or a med name, go see my friend over here and say, explain this one to me, because sometimes, you know, when they add new meds and you haven't seen them, so it's always like calling my resources to say, hey, help me, and I'll say, this patient has this, can you explain it to them? And she's really good with that too. Or I call up to my cardiology nurse and say, please explain this to me, because I'm not cardiology, I'm primary care, and that's her specialty. And she's very helpful with me with explaining how they meds. She explains with me about diets for the patients. And she, you know, helps me so that I can help my patients. And sometimes I do still have to send them back to my cardiology nurse, but she has been very helpful with helping me with meds and all the other things about keeping my patients safe.
Yes, that's key right there. Well, that's it for me, but you know, I don't know if anybody has any last minute things to say or any take home points.
I would just say heart failure is so complicated. All the points brought up about taking meds, about being aware of side effects, about having all these, this huge life adjustment of taking all these medications. It's hard. And so having a team approach where the primary care is engaged, and because you got other things to take care of beyond just heart failure.
Right.
You know, so getting the team involved, getting the tough love from the nurses up front, and getting all the pharmacists who are experts in the meds. You can really have some very clinically satisfying results with a whole team approach, and it really helps the patients. So thanks for all you're doing.
Thank you. Any last
No,
words?
I truly appreciate the team efforts, and you know, Dr. Seinstick is always available curbside. I've reached out to him on a couple occasions, so I think this has really kind of helped me better manage some of the patients, you know, co-manage the patients.